So we're talking about some of the common medications we run into that people may abuse or substances they may abuse and overdose on. Talk about some of their reversal agents. And especially talk about a couple of the new things like high-dose insulin and lipid therapy for treating some of our cardiotoxic substances. So which of the following urinary findings would be associated with an ethylene glycol ingestion? What might we see in the patient who ingested ethylene glycol? We're going to see calcium oxalate crystals, yes. So one of the things we have to worry about with ethylene glycol ingestion is it turns it into oxalic acid, which forms significant crystal formation, can lead to renal failure. One of the downsides we have to worry about with ingesting the patient's ingested ethylene glycol. One of the cool things about ethylene glycol is it tends to fluoresce. So if you hold their urine up to a black light and it glows, that confirms they ingested ethylene glycol. A family has presented with multiple complaints of symmetrical muscle weakness, began the upper body, and is now descending to their legs. They also complain of drooling and dysphagia. You suspect, good, botulism. This is botulism. Botulism usually causes an acute descending paralysis, where things like Guillain-Barré is an acute ascending. An elderly patient complains of arthritis, tinnitus. The patient's been taking non-prescription pain medicine for the pain relief. Based on the patient's chief complaint, the clinician should ask about the use of what causes tinnitus? This is aspirin. In aspirin toxicity, the patients often develop that ringing in the ears. A patient presents who reportedly ingested an unknown amount of acetaminophen. At what time frame should the first acetaminophen level be drawn? When do we want that? At 4 hours. It's the 4-hour lab level. So if I know when they ingested it, I want a 4-hour lab test, and that tells me if they're toxic or not. If we don't know when they ingested it, we'll draw one now, and then 4 hours from now. But within 4 hours of ingestion, we'll know if they're toxic or not using our nomogram. So we talk about general management of the tox patient. Some things have changed, luckily, over the last couple of years. Things that we do, we don't do. We no longer do syrup of ipecac. We don't induce vomiting anymore, thank goodness. We rarely, if ever, induce gastric expansion and evacuation. Very rarely will we ever be told by toxicology that, hey, I want you to drop down a tube and pump out their stomach. It doesn't work. For most things, by the time we get them, they've already been passed from the stomach and the small intestines, and this doesn't work very well. So very rarely do we ever lavage or do we ever induce. We still do activated charcoal, and in most things, activated charcoal is effective if given within 4 hours of the ingestion. There's a couple exceptions, but charcoal does work. We may do a whole bowel irrigation with polyethylene glycol, especially with extended release medicines, or if they're the mule or the packer who swallowed a couple condoms or baggies full of heroin or meth, we're probably going to go ahead and give them some Go Lightly. And then some things that may just be hemodialysis. Hemodialysis may allow us to remove certain things. Some things it doesn't work on, like tricyclics, but it does allow us to at least address their acid-base imbalance. So we may use a combination of these things depending on the substance, depending on the patient. But luckily we're not doing too many E-walls anymore and pumping out their stomach, because that was always just a bloody mess. As I mentioned, charcoal works for most things if given within 3 to 4 hours of the ingestion, except for these. It doesn't affect the absorption of pesticides, hydrocarbons, and on down the list. Our biggest thing to consider if we're giving activated charcoal is what is the patient's mental status. If their mental status is altered, we probably should secure the airway before we give charcoal so they don't vomit and aspirate. This is literally just round up charcoal briquettes. And we probably don't want them to get a chemical pneumonitis because they've aspirated charcoal in their lungs. But it works on most things. As I mentioned, it won't affect certain things, but the whole goal here is that charcoal will actually bind to that substance and facilitates elimination without absorption. Some things may require multiple doses. Some of those slow-release agents are if they took large doses. And those are usually things that poison control or toxicology will help guide us on. But definitely just keep in mind What is their mental status? Do we need to secure their airway first? And if it's been greater than 4 hours, probably not a benefit. So this table just kind of gives us some common reversal agents. We'll talk about some of these specifically. We've already hit several of these throughout the day. But like benzodiazepines, it's flumazenil. How often do we give that? Pretty rarely. Most scenarios with benzodiazepines, we manage the airway. We control their bleeding and then let the drug wear off. Our biggest concern with the benzos is the risk for withdrawal seizures. Now, this is the pediatric patient who's probably not a chronic benzo user. We're probably a little safer there. But most clinicians will say, hey, let's not reverse them. Let's just manage the airway, manage their breathing, and let the drug lose its effectiveness and they'll wake up. But if we need to, we may have to secure their airway. We'll talk about some more of these throughout. So in our heavy metals, gold, arsenic, iron, lead, we may use some type of chelating agent. And there's various ones out there, and this usually definitely involves toxicology, poison control, trying to figure out what is this problem. But definitely we can run into kids who ingest a lot of iron, or people who get lead poisoning from old pipes or paint, especially if they have pica and they're eating the paint chips, they definitely get problems. But these chelating agents are going to bind to and help us remove that metal from the body. That's usually just going to urinate it out through the kidneys. Some of those out there like BAL, phencylamine, EDTA, dysfroxamine, the very last one's usually our drug of choice for iron poisoning. The biggest concern that usually is with pediatrics, especially if mom is pregnant and they take mom's pregnancy prenatals. Those usually have a very large iron content. Iron can cause severe acidosis, can cause hepatic and renal injury. So usually we'll check an iron level. That's the one time we'll actually get an x-ray. If you ever see anybody who ingested a lot of iron, they get an x-ray, you'll see it on the x-ray because it's literally elemental iron. And on that KUB, we'll see this big thing of metal there in their gut. And that's definitely a reason to do a whole bowel irrigation and to give the difroxamine, which is going to help chelate that excess iron out of the body. So we talk about tox. We have a couple of general toxidromes we usually think about, like the anticholinergics. And we'll go through some of these. The cholinergics, definitely our opioids, our cardiotoxics. We generally approach the toxic patient. ABCs is always our priority, just like anything else. Any patient who's altered, make sure we get a glucose. Some of these substances may affect glucose uptake, some may affect insulin release. And if I had to have one drug, it's probably going to be a benzodiazepine, because benzos are going to help control the hyperactivity, their seizures, their hypertension, their tachycardia, their hyperthermia. All that can easily be controlled with benzodiazepines. We like a lot of benzos for a lot of tox emergencies. So our anticholinergic effects versus our cholinergic effects. We may see some significant physiological changes here. So anticholinergics, what are some sources of anticholinergics? Where might someone get an anticholinergic exposure? So a lot of our antihistamines, like Benadryl, have anticholinergic effects. That's why most over-the-counter sleep aids, if you overdose on them, you're going to get those anticholinergic effects. A lot of our antidepressants, a lot of our antipsychotics may have those anticholinergic effects. Jimson weed, we'll sometimes run into people that are using Jimson weed. That also has anticholinergic effects. So what we see with anticholinergic may help us differentiate what we see with a cholinergic crisis. Where might I find a cholinergic crisis? These are your organophosphates, your insecticides, your pesticides, your nerve gases. But look how we can look. With an anticholinergic, they usually have mydriasis. With the cholinergics, they're usually very pinpoint. If they have anticholinergic effects, they are dried up. But if they have cholinergic, they're losing all that bodily fluid. So vital signs help us a lot differentiating some of these. Looking at their skin, we talk about opioids versus sympathomimetics or sedatives. What's their core temperature? What's their heart rate, their respiratory rate, their blood pressure, their eyes? What does their skin look like? What does it feel like? And those are some ways that can sometimes help us differentiate, because sometimes these can look very similar. So some of the other agents that have anticholinergic effects, belladonna, All of our antihistamines, scopolamine, I was talking to a gentleman at the break about that. Some of our anti-Parkinsonism agents, some of those H1 blockers we mentioned. A lot of our GI drugs like promethazine, prochlorperazine, those all have some anticholinergic effects. Normal dose, not a problem. But if your patient decides to take the whole bottle, that's where we're going to see those anticholinergic effects. The mad as a hatter, hotter than Hades, sick like a seizure, blind as a bat, those are your anticholinergic effects. Anticholinergics get that significant mydriasis, so they can't see. They start seizing, they get hyperthermic, they get psychotic, they get crazy. They dry up all their secretions, they have no spit, they can't pee, they can't poop. That's anticholinergic effects. So other things that are out there that we talked about, like Datura, some polypharmacy things, especially some of the antipsychotics and the tricyclics cause significant problems. So we definitely may see different presentations here with their mental status, with their hyperthermia, with their seizures. Treatment usually is going to be supportive. Most time we don't reverse their cholinergic effects, but we may with physostigmine. A big focus is going to be on ABCs, benzos if they're having seizures, and sodium bicarbonate infusions if they're having significant EKG changes. One of the things we always have to worry about with a lot of these ingestions is co-ingestions. Do they take one thing? Almost always no. They took something else with it. And sometimes the other thing tends to be ethanol. And it's very common to see that them ingest a lot of ethanol with whatever else they take, and that may either delay the onset of the toxicity or may exacerbate it. So I gave this table just to kind of look at some of the benefits and the role of physostigmine, something we usually don't use first line, but definitely something that toxicology may recommend in severe toxic overdoses or exposures. But usually it's not our first line process. The tricyclics. These are drugs we used a long time ago and were really effective for treating depression, but they've become replaced now with a lot of the SSRIs and SNRIs. The tricyclics were really effective, but they had lots of toxic concerns. If they overdosed, they had a lot of cardiovascular and a lot of neurological problems. QT prolongation, seizures. And then usually they mix this with something else, even more problems. But definitely a huge anticholinergic effect from our tricyclics. So anytime you see that patient with a wide QRS, think about cardiotoxic problems. That tells me they've got a sodium channel blockade. We sometimes see that with our CNS agents like cocaine. We definitely can see that with our tricyclics and any of our anticholinergics. We start to see that widening QRS. That makes me really concerned about a sodium channel blockade. So we secure the airway if we need to. Our focus is going to be on systemic alkalization. The whole goal here is to alkalize their urine. If we alkalize the urine, that's going to increase excretion of the tricyclic and help facilitate faster removal. We may try hemodialysis, but hemodialysis is not very effective for tricyclics because tricyclics are very tightly protein bound. So we'll do systemic alkalization, trying to facilitate excretion that way. If we need to support their perfusion with fluid boluses or vasopressors, we may try dialysis, but it's not always effective. But if they're having significant QRS prolongation, that's definitely going to be a reason to give bicarb as well to help control that sodium channel blockade. That's usually their cause of death, is they get such significant widening, they go into lethal arrhythmias, and they die. So our cholinergics we alluded to a little bit earlier. This is your organophosphates. This is your sludge. This is also your killer bees, the bronchorrhea, the bradycardia, or your dumbbells is another one for these. But with these cholinergic crises, we get a significant activation. We lose a lot of fluids, and they can lose their airway very quickly. Our organophosphates are a big risk here. Uses a lot with insecticides. So we see this a lot during that time of the year. If people don't wear proper protection, they get a lot of dermal absorption. During chemical warfare, we see this, where people are exposed to these organophosphates, sarin, soman, VX. They're easily absorbed dermally or inhaled, and they have significant cholinergic effects. They also can have some significant muscarinic effects, and that can lead from diaphoretic paralysis and they lose their airway very quickly. So our first-line agent is usually an anticholinergic like atropine. That's going to help address all these cholinergic symptoms. It buys us some time because they're having all this bronchorrhea, all this salivation, this bradycardias. We're going to buy us some time with atropine. There is no max dose here. You will give them every purple box you have. That typical 3 or 4 on the crash cart, it's gone because we gave that in the first minute. We're giving lots of atropine, but the drug we need is the 2-PAM, the peroxidine. That is the drug that will stop this overactivation and free up these receptors. The sooner we can give the 2-PAM, the faster we can stop the cholinergic crisis and reverse these toxic effects. If you get that organophosphate on you, you're probably going to get the same symptoms. It's rapidly absorbed dermally. So we use lots and lots of atropine to control a lot of this, and definitely need to think about giving the 2-PAM. We're going to get the head of the bed up as soon as possible because they're going to have so much bronchorrhea and so much salivation and so much GI loss. Atropine, 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 till we have access to 2-PAM. Luckily, something we don't see a whole lot of, but definitely can be very fatal when we do. So I mentioned a little bit earlier, but flumazenil definitely is our reversal agent for our benzos. Usually it's not a first-line agent we think about. Maybe in pediatrics, or maybe that patient who we've been doing a procedural sedation and they got a little bit too much midazolam. But in most patients, it's not my first line because of the risk of withdrawal seizures. I've got your doses listed for you here. We'll try a small dose. If that doesn't work, we'll try another dose. But for most people, it's easier just to manage the airway, maximize ventilations, and let the drug wear off. So are opioids. This is your CPR-3H. All of our opioids are going to cause reduced mental awareness, mental status, those pinpoint pupils, respiratory depression, hypo, almost everything. Hypotension, hyporespiratory rate, bradycardia, hyporeflexia. Typically, our first line is going to be naloxone. Most will say start low and titrate up. Typically, initially for most people, our goal is not to fully wake the patient up. My goal is to wake up the respiratory drive. Because do you want the patient who's sleeping but breathing, or the patient who's really tacked off because you just took away their heroin dose? So depending on how much you are at having fun, we start out with like 0.2 or 0.4 versus 2 milligrams off the bat. Your choice. But probably most people would start low and titrate up. If I don't have IV access, we've talked about it several times, intranasal is a good option. One of the nice things about going intranasal is there's no blood exposure. So there's a lot less risk of blood exposure if I'm worried about some contractable infections from blood things. In some areas like FDNY, their first line is almost always intranasal naloxone because they can quickly give it that way or they go IM, so there's less risk of blood exposure. So with these patients, everything gets slowed down. Our biggest concern usually is the respiratory system. So hey, let's wake the respiratory system up, let them breathe, let them oxygenate without waking everything else up until we're ready. Because if we wake everything else up, that patient's not going to be happy. And this is a chronic opioid user, they're going to experience some significant withdrawal symptoms, and those are not pleasant. Naloxone works very quickly. The nice thing about it is it's rapid acting. The downside is it's short acting. The half-life of naloxone is usually around 60 to 90 minutes. The half-life of most opioids is much longer. So a lot of times these patients are going to require repeated doses of naloxone or may even require an infusion. But if you fully reverse that patient, they're going to experience withdrawal symptoms. And it's not going to be pleasant for them and probably not be very pleasant for us. So we can give it IM, sub-Q, intranasally. We now have those auto-injectors that are out there. There's even kits now for intranasal injection that you saw in that video. But typically the goal for most of us is to start low and titrate up. There's definitely been cases where we've had people ingest large amounts of contaminated heroin with carfentanil or something else, and those patients may require more, but I'd rather easily add on, because you can always add to, it's just sometimes not easy to take away from. I think all states now have laws that address the co-prescribing of naloxone with certain medications, In some states, it may be available without a prescription. They can walk into the pharmacy and get a naloxone auto-injector. Gave you this link to look up some of the state-by-state listings of regulations. I know some hospital systems, anytime they order an opioid for prescription, it automatically prints out a naloxone auto-injector for the patient as well. Depends on your health system. But definitely those are things we can consider. Initially, when the auto-injectors came out, they were there for treating people with chronic pain, so if they accidentally overdosed. But now we're seeing more and more of substance use disorders, and people are using these. And they're very rapidly available in a lot of now law enforcement carry them, fire departments, even if they don't do medical service, they still have access to those. In addition to opioids, naloxone can be effective at reversing a lot of other things. And this is your rock lava X. So Respirine, opioids of course, Clonidine, Lamodal, your ACEs and ARBs, valproic acid, Aldomet, and Xanaflex can all be reversed by giving a large dose of naloxone. Typically for opioids, we start at 0.4. For all these other agents, the recommendations usually start at 10 milligrams. Naloxone in high doses will reverse the effects of our central alpha-2 agonist, our ACEs, our ARBs, those things that affect the gut like Lamodal. So definitely that patient comes in, they're altered, they're unresponsive. The most common one I see here lately is Clonidine. Kids are on Clonidine now for ADHD. We use it for other things, and they've ingested the whole bottle of Clonidine. They come in looking almost like an opioid ingestion, but there's no access to opioids we know of. You give them 0.4 of Narcan, nothing happens. Give them a milligram, nothing happens. We finally get their med history. Oh, they're on Clonidine. We hit them with 10 milligrams, and they wake up. Their vital signs improve, but in about an hour or two, it starts to wear off. And they start getting sedated again and start getting bradycardic and bradypneic again. And so we usually end up hanging an infusion of naloxone. This is definitely something toxicology will probably recommend pretty quickly if you haven't come to there yet, especially with his other agents. Clonidine is probably our most common here lately. Aldomet's also a central acting alpha-2 agonist we'll run into. But that patient's been out eating a lot of Lamodal or a lot of Imodium trying to get their opioid fix. Clonidine will also help reverse those. So that's a little tool to have in your back pocket. When assessing the vital signs of a patient who ingested gamma-hydroxybutyric acid, GHB, Georgia Homeboy, G, a few hours ago, you'd expect the patient would have the following vital signs. We don't see GHB as much as we used to in some areas, but it's still used, still abused. You can obtain it illegally in some places online. What does GHB do? It is a CNS depressant. It's a CNS depressant. Sometimes used as a date rape drug. Different than Rohypnol, that's a barbiturate, but GHB is sometimes used for date rape or just for enhancing sexual pleasures. So it typically will cause us to have it'll drop the core temperature, drops the respiratory rate and the heart rate, but usually their blood pressure stays normal to low normal. This patient comes in, they're unresponsive, or they wake up, they're amnestic to the event, their typical drug screen is negative, it potentially can be GHB. Usually in small doses, GHB causes some euphoria, may enhance certain pleasures, but in larger doses, it leads to rapid altered mental status, unresponsive state, and that's when we see a lot of our date rapes. It's colorless and tasteless, can easily be dropped in someone's drink, or can be injected. Sometimes it's used as a combination of things, sometimes it's used by itself. But these patients usually come in unresponsive, they wake up, they're totally amnestic, we have to worry about sexual assaults. This will not show up in your typical drug screen. One of the things that we'll sometimes see is they get a lot of nystagmus, and they may have a lot of incontinence with it as well. But treatment is purely supportive. ABCs, watch them, let them wake up. So kind of give you a comparison, Rohypnol, some other ones, ketamine. Rohypnol usually about 20 minutes where GHB is 15. Ketamine's a little faster, but ketamine has a shorter onset and a shorter activity usually. But these people will remain altered for 3, 6, 10, 12 hours, depending on the drug. And unfortunately, there's a lot of other drugs that are sometimes ingested as well. Anybody familiar with trail mix? People that use trail mix. So what they'll do is they'll get a little bit of G or a little bit of K, so a little bit of GHB, a little bit of K, ketamine, and they'll mix that with some mollies, some MDMA, ecstasy, and they'll add a little sildenafil. And that's trail mix. Hey, they gotta have a good week. It's Vegas, right, baby? That's trail mix. So our sympathomimetics, our stimulants, outside of THC, the sympathomimetics are the most commonly abused class of drugs. This is your mass. These are going to cause significant cardiovascular and neurostimulation. The mydriasis, they get the dilation, the fight or flight. They may just have euphoria, or that could become agitation, paranoia, tachycardia, hyperthermia, hypertension. They start sweating a lot. They may start seizing as well. Your mass. These are stimulants. Cocaine, amphetamines, methamphetamines, mollies, bath salts, K2, spice. Which of the following medications would be contraindicated in the patient with a methamphetamine-associated hypertensive crisis? They've done a little meth, now they're tweaking out. They're hypertensive as all get out. What should we not give them? Let's not give them metoprolol. So with these sympathomimetics, they usually get a significant overstimulation of both alpha and beta through catecholamines. We know that alpha and beta keep each other in check. And if I block beta but do nothing with alpha, that leaves alpha unopposed. So the recommendations on all these sympathomimetics is block beta and alpha both, or don't even go to an alpha-beta blocker, use a benzodiazepine, because that will block everything. So usually a benzo is my first-line agent. We may give vasodilators like nitro. If we need to give a beta blocker, we'll probably go something like labetalol, so it gives us both alpha and beta blockade, but not a pure beta blocker like metoprolol, because that will leave alpha unopposed, and it may make their hypertension much worse. So these drugs, people smoke them, they snort them. Now we're seeing a lot of vaping. They're putting all these in electronic cigarettes, and they're going around vaping their cocaine, or their meth, or their mollies, or their bath salts. But they stimulate everything. So alpha stimulation, beta stimulation, the mydriasis, the hypertension, the hyperactivity. Initially, it may just give you some euphoria, some increased energy. Within more stimulation, you get significant paranoia. It may cause psychosis, hallucinations, psychotic events. Cocaine's really bad about causing coronary vasospasms. And while people coming in with chest pain, looks like they're having a STEMI, they get to the cath lab, coronaries are clean. It was a vasospasm. And unfortunately, a lot of these drugs are not pure. So what they think they're getting is some cocaine may actually have something else in it. It may just be baking soda, or it may have a little bit of MDMA, or may have some bath salts, or may have carfentanil, or may have whatever in it. I mean, if you can't trust your drug dealer these days, who can you trust? Like, dude, I just wanted some cocaine, but you gave me meth. I like my teeth. So this is your sympathomimetic patient. They are tripping because they got all this cardiovascular and all this CNS stimulation. Hyperthermia becomes a big concern, which means they can go into rhabdo, go into acute kidney injury because they get really hot. With some of these drugs like bath salts, we're seeing 105, 106 core temperatures because they're so overstimulated. Treatment is going to be benzos, benzos, benzos. We'll give IM, IV, intranasally, whatever it takes. And sometimes these people, they will go through 10, 15, 30 milligrams of midazolam. And they're so hyperstimulated, they're so hypermetabolic, they will chew through these drugs really fast. Like, this guy's had 20 of Versed. There's no way he's still talking. Oh, he still is, because he's so hypermetabolic. Hydration is important, because they tend to get a lot of hypovolemia from dehydration from the hyperthermia. If you see that wide QRS, they need bicarb because they've got a sodium channel blockade. If benzos aren't working, we may go to nitro or nitroprusside for the hypertension. If we need to go to a beta blocker, we'll use labetalol or something that's going to have alpha-beta properties. Charcoal works well if given early, if it's an ingestion. And what are all these little things? What are those little things? Oh, those are little baggies. Those are little baggies of stuff. Yeah, and if one of those ruptures, it's a bad day. So this patient's going to get a good dose of polyethylene glycol, hopefully, to flush them out, or they're going to go to the OR and have to have all these little baggies cut out. But benzos, benzos, benzos. You can't usually give them enough. And a lot of times they end up getting a lot of bolus, and then they're going to end up in an infusion, sometimes 10, 20 milligrams an hour. If benzones aren't working, we may go to ketamine, or we may add in some antipsychotics. So lots of things that we can see with these drugs. They start having significant seizure activity, throw in more benzos, or go to something else that we have to use. But lots of hyperstimulation. If need to, as a man, we'll throw in an antipsychotic. Ketamine's a good option. These people present just like excited delirium. They've already got tenoverset on board. Giving them 500 of ketamine is not going to cause any more hyperstimulation. It's like some of our old patients on PCP or LSD. They are stout and they are strong. So I made a couple allusions to this, but K2 or spice. If you've never run into this, K2 or spice, this is sometimes referred to as the legal THC. These are this potpourri, this herbal incense that's been treated with chemicals that stimulate the cannabinoid receptors just like THC does. But usually it's much more potent. In addition to stimulate those receptors, it also gives us some catecholamine effect. So people use these, they get the euphoria, they get the effect that you'd usually get from smoking THC, but sometimes they use it too much and they get the catecholamine effect, and they use it more and more, and they develop a tolerance, and it takes more and more every time. So why do these become so popular? Why aren't they just going out and smoking a joint? Why are they smoking this? This doesn't show up in your urine drug screen. Exactly right. And so people that have to pass a drug screen for whatever purpose, they've learned that, hey, if I go out and do some K2, it doesn't show up in my drug screen. Most urine drug screens look for the metabolites. So I'm looking for the metabolite of THC. I'm looking for the metabolite of whatever. This has a different metabolite because it's synthetic. So it doesn't show up. And then it's changed the formula tomorrow. So there's really no need of even benefiting and making a drug screen for this, because you change the formula just a little bit, now the metabolites are different. But if someone's really tweaked out on some K2 or spice, it's benzos, it's benzos, it's benzos. And then not to make it bad enough, last year we had a significant outbreak in Illinois, and then saw some in Kentucky, and I even saw some in Tennessee, with people who were coming in coagulopathic. They come in, they were bleeding from their gums, their nose. Their INR was 18. That was the highest one I saw. Like, what the heck's going on? I'd heard about this. The patient finally admitted she had been smoking some K2 to pass her drug screen, and she had smoked contaminated K2. That somebody out there decided, hey, we're going to add a little bit of this anticoagulant, which is very similar to warfarin, to this mixture. And so now everybody who smoked that K2 got a dose of this, and now they were severely coagulopathic. So definitely if you run into the patient who's coagulopathic, they're not on warfarin, there's no liver history, this is one of the questions I'll be asking about. Have they been doing K2 or spice? And these patients need vitamin K, and they need FFP or PCC, just like your warfarin patient. So bath salts. These are synthetic amphetamines that you can get illegally. It was developed to mimic cathinone, which is the stimulant agent in the khat plant that's sometimes used in Africa and other parts of the world. You chew on it. If you ever saw the movie Captain Phillips, and one scene the Somali pirates on the beach and they're chewing on something, that's khat or cat, K-A-T. That's the stimulant. Well, these bath salts are developed to mimic that. So you can smoke it, you can drink it. This is not for your bath water. Soothing bath salts, not hardly. Different versions out there, but these enhance catecholamines. They influence serotonin levels. dopamine, norepi, and sometimes cause that empogenic response. They smoke it, they drink it, they vape it. There's now even cases of people butt-chugging this. So instead of butt-chugging ethanol or soaking a tampon in ethanol, they're soaking it now in bath salts and inserting that. Whatever. But these people have some significant excited deliriums, hyperactive, hypertensive, become really hyperthermic. Lots and lots of benzodiazepines. If we need to, we may have to add in antipsychotics or add in some ketamine. Some significant complications. What we're seeing now is people that have been abusing bath salts, they're developing Parkinson-like syndromes. They're in their 20s and 30s, and now they're having Parkinson-like features because they depleted all their dopamine stores. And that's a permanent thing they're going to have for life because of using these bath salts. But now we also have second-generation bath salts called gravel or flakka. So the first generation, that wasn't enough. Now we got to have second generation. And so now we started mixing bath salts with a little methamphetamine, maybe throwing a little rat poison or something else. We need a little filler. And literally they've been found some of it had rat poison in it. And now people are doing this. And it looks like really gravel in that little baggie. A lot of this happened down in South Miami in Florida. This is one of my favorite stories. This guy is high on flakka, and he is trying to procreate with a tree. The police get there, and this guy is naked as could be and humping a tree, saying he's Thor, god of thunder. And he is high as could be on flakka. Benzos, benzos, benzos. These drugs are highly addictive, and they develop a rapid tolerance. So it takes more and more each time to get the desired effect. And that brings us to this. Involuntary teeth clenching and an adverse effect of which the following substances. This is classically associated with ecstasy. Ecstasy causes significant master muscle teeth clenching. That's why you see a lot of people doing X sucking on a pacifier. If you see somebody over the age of 3 with a pacifier, they're doing X. But you ever see people with a ribbon around their neck with a pacifier on it? They're doing ecstasy. And this helps with the master muscle teeth clenching. If they usually love EDM, electro dance music. They love those big music festivals, and they're out there with their pacifiers, and they usually glow in the dark or have flashy lights like you see there. They love those pretty colored lights. So Molly's plant food, which is MDMA, which is ecstasy, so methamphetamine, tends to cause that euphoria. It has that empogenic effect because it affects serotonin, dopamine. It also affects oxytocin and increases oxytocin release, which is why it's sometimes referred to as the love drug or the hug drug, because it gives that empogenic effect and people want to be close to one another. Anybody ever been to or worked a rave? Oh, they're out there dancing, they'll wear their fur pelts, that's their spirit animal, and they're doing all this EDM stuff. That's your typical Molly's person. That's your EDM stuff. Euphoria. It's feeling good. But then sometimes paranoia, hallucinations, hyperthermia, psychosis can even happen. One of the other things we know about MDMA is it suppresses ADH. It affects our thirst response. Most amphetamines can do that. So people that do a lot of Molly's, they know that, hey, dude, you're going to get thirsty, but you're not going to feel thirsty. So you need to drink lots of water so you don't get dehydrated, because they often get hyperthermic. And so they will chug and chug water, and next thing you know is they're in the ER seizing because their sodium is now 110. So definitely if you're dealing with anybody who comes from a rave or an EDM festival and they're seizing, it's probably hyponatremia from drinking too much water. But they love pretty colors and flashy lights. Lollapalooza, Base Nectar, Life in Color. If you ever had the chance to do event medicine, it's an experience, I promise you. But long-term complications because these are highly addictive. They have cravings. It takes some today, tomorrow it's going to take more, and the next day more, and the next day more. And who's to know if this drug is pure or not? It's not always. It's contaminated with other things, or maybe a mixture of multiple things. But those are some of the sympathomimetics we run into. If I had one drug, it would be a benzodiazepine. If they have a wide QRS, it's going to be sodium bicarbonate. So we have this 60-year-old patient who comes in by EMS. He's altered, he's hypotensive, he's bradycardic. So what am I concerned about already? Toxicity, probably. This is a tox lecture. But what toxicity is this? I'm worried about my cardiotoxic drugs. That's probably my most common here. And so here's his home medicine list. He's on metoprolol, diltiazem, atorvastatin, and aspirin. So we got beta blockers and we got calcium channel blockers. That's the perfect picture for a cardiotoxic scenario. So what are we going to do to manage this guy? He's hypotensive, he's bradycardic. We think he's overdosed on his calcium and his beta blocker. What's our treatment going to include? Glucagon, good. Fluids, we could try atropine. Anything else? Calcium, maybe. And we'll talk about some of the newer things. So glucagon is usually our first-line agent for reversal of a beta blocker or a calcium channel blocker overdose. Glucagon allows us to stimulate the beta receptor without using the beta receptor. The glucagon pathway is parallel to the beta pathway, and giving glucagon allows us to stimulate that, activate adenylyl cyclase, and give us some stimulation without using the beta receptor. Glucagon works pretty well. Anybody ever given IV glucagon or had it given? What's the big concern I have to worry about? Vomiting. Glucagon also is a prokinetic. So almost always people that get IV glucagon, because we're talking about 3 to 5 milligrams, they need to get an antiemetic first. And usually the slower you give the glucagon, the less likely they are to spew. They may still spew. But typically these people are going to get a bolus and then an infusion. And that works pretty well to reverse the toxic effects of beta blockers and even calcium channel blockers. But two of our new things now are things like hyperinsulin therapy or high-dose insulin therapy. So very similar to DKA, we'll start these people out on insulin infusion. But instead of going to just 0.1 unit per hour, we may end up going to 1 unit per hour or per kilo, and then 10, 15, maybe 100 units per hour. Very similar to glucagon, insulin is going to allow us to bypass that beta receptor or that calcium channel, activate those receptors, and increase contractility, increase the heart rate. But also we're increasing glucose uptake in the cell, which is a great source of energy. So in several published case studies, high-dose insulin has been very effective at reversing beta blocker and calcium blocker toxicity. We definitely have to watch their glucose levels very closely as they're altered on a D10 or higher infusion, and definitely have to watch their potassium levels. But definitely the patient who's on an overdose of these, they're not responding well to traditional treatment. We tried the glucagon, or I might not have a lot of glucagon available. Most people don't walk around with 50 units of glucagon in their hospital. So we have to go to something else, and this is definitely something that toxicology may recognize or recommend. So usually we're going to start with a fluid bolus, go ahead and give some IV calcium, address their glucose, probably going to need some dextrose, start an insulin infusion, and then titrate to effect. And sometimes they may be on a couple of 100 units per hour. So lots of frequent glucose checks. The other big thing is insulin is going to be lipid therapy. Just like we're giving TPN with lipids, the same thing here. So especially with drugs that are lipophilic. Some of our calcium channel blockers, a lot of our non-selective beta blockers are lipophilic. Given this dose of intralipids is going to create an attraction of those drugs, because now have this lipid component in the blood vessels, and thought to create what we refer to as the lipid sink, and pull those drugs out of the heart, out of the vascular walls, and free those now up to be stimulated and activated. Lipids are also a great source of energy, so now I have free fatty acids available for cells for energy production, and these have both been found to be very beneficial at treating a beta blocker or a calcium channel blocker overdose. This is off-label, so it's not FDA approved. This is the protocol here that they use over in England. Anesthesia's been using lipids for years to treat lidocaine overdoses or any of our cane overdoses, to treat those. but giving them the bolus, hain infusion. And one thing to consider if we're doing high-dose insulin or intralipid therapy, as soon as we start those, get ready to start turning down your other things like your vasopressors or your inotropes. Because if you've already got them on an epi or a norepi or a dobutamine infusion, once we start these two therapies, get ready to start turning those down because they're going to become more reactive. And there's several good case studies published that show within 2 hours, these patients are off all their vasoactive and inotropic drips, and they're just getting their insulin or just getting their lipid therapy. So they're really effective, but take a lot of bedside time. That's why I usually want to get these people up to ICU as soon as possible so they're not eating up our bedside time. But they definitely can be very beneficial. Last few things. What about cyclic vomiting syndrome? All those patients that come in, they've been wearing out the THC, and they now have this cyclic vomiting syndrome. Some things we found that be beneficial. The best thing for them is to stop smoking. THC may have some antiemetic effects for some, but for these patients, it's their trigger. Most of them don't want to accept that, but it's their trigger. Sometimes hot water exposure may help this. One of the things that's really come out in the last couple of years is capsaicin. So capsaicin cream that we may use for like osteoarthritis or other areas for panic neuralgia may have a similar benefit. Capsaicin creams tends to deplete substance P, which plays a role with pain transmission, and probably has a similar benefit to the hot water, the hot showers that we recommend sometimes these patients do. Benzos may be very helpful. Antiemetics are usually not very helpful. The treatment's got to be focused on abstinence. If they go back to smoking, they're going to get this again. But probably one of the best things that we've seen that help, besides the hot water, is going to be probably something like capsaicin cream.
Where are you putting the capsaicin?
So with the capsaicin cream, we can put it anywhere, usually the patches, but if you have just the topical cream just rubbing on their body, tends to deplete that one area, which tends to be effective. So hot showers will leave about symptoms in about 60% of patients, and definitely may get some conditions with other problems. Some other things that may help, antipsychotics like Haldol or Droperidol, those are actually two really good antiemetics as well, that they work totally differently than some other things. They're not like our Thorazines or our ondansetrons. And that definitely in some people that have retractable nausea and vomiting, a first-generation antipsychotic may be very helpful also. What about wax or Buddha? They come in, they've been doing a lot of Buddha. So what they'll do is they'll take and extract the oil out of the THC, and they're pulling out that oil, and it looks very similar to this when they extract it. And then they'll concentrate it, and sometimes they'll put it in a little tube, just like chapstick. And they just walk around, they just rub on their THC, and one application is about the same as smoking 15 or 20 joints. And these people are getting significant toxic exposures because they're like, oh, I can smoke a joint or two, but not 15. So we're seeing some toxic cases of that. And then also, a lot of times these people will use butane, as you see there, and they use the butane to extract the oils. Well, we know what happens when somebody tries to use butane. It usually doesn't go very well, and there's an explosion, and there's lots of burns. But definitely some states may have competition to see who can make the best butter. And they'll sometimes use the butter for cooking, for some of those edibles as well. And one of our last things to talk about is the toxic alcohols. So a lot of these toxic alcohols, ethylene glycol, methanol, are usually seen as alcohol substitutes. So if it's that time of the month, I'm an alcoholic, I don't have money, I don't have resources, my check hasn't come yet, I need some ethanol. Well, they can't get ethanol, so they'll go drink something else. Sometimes that's rubbing alcohol. Sometimes that's ethylene glycol, antifreeze, or sometimes that's methanol, which is found in some brake fluid, windshield wiper, formaldehyde, and embalming fluid, all those wonderful things. So methanol and ethylene glycol are not toxic. It's what our liver turns them into that's toxic. So if your liver doesn't do its job, you're fine. But the liver is going to turn those into bad things. The liver turns ethylene glycol into oxalic acid. It turns methanol into formic acid and formaldehyde. Probably not things we want floating around our body just yet. They both cause significant gap acidosis, can cause severe organ dysfunction. They will get you drunk really fast. Treatment is going to be the administration of fomepizole. Fomepizole is going to inhibit alcohol dehydrogenase, the enzyme that metabolizes our alcohols. If you don't have fomepizole available, cannot get them to fomepizole very rapidly, we may consider the administration of ethanol. You see this a lot before we had fomepizole. But if we give the patient ethanol, ethanol will delay the metabolization of the bad things. Your liver would rather metabolize ethanol than it would ethylene glycol or methanol. So it's a delay tactic. But fomepizole is the drug of choice. It doesn't take a lot. 1 gram per kilogram is lethal. So we administer the fomepizole, or if we don't have it available, we can go to ethanol. The ethanol is not FDA approved, but it's an option if we don't have fomepizole available. In most scenarios, if we can get the fomepizole fast enough, they may not even need hemodialysis. But if we haven't gotten on board fast enough, we're usually going to still dialyze them to remove those toxic metabolites to prevent other organ damage. So the goal with the ethanol, the goal is to get their blood alcohol up to about 100 per hour and leave it there. So if I get their blood alcohol to 100, that's sufficient to suppress metabolism of the other things and let the liver stick with the ethanol. But you got to get them there and keep them there without getting them too drunk, and that's the challenge. But definitely that's their goal. Which of these medications would you order for the patient who ingested the sulfonylurea and has refractory hypoglycemia? Talked about this earlier. This is sandostatin, not Octreotide. As I mentioned, any patient who comes in and they're hypoglycemic from an oral agent, they really should be admitted for observation. And if they have refractory hypoglycemia from a sulfonylurea, it's going to be Octreotide. Administer this as a bolus, as an infusion. It's going to suppress the pancreas's release of insulin in response to that drug. That's all it simply does. Cyanide poisoning. Cyanide usually comes from the combustion of plastics, wool, some other synthetic agents. Usually we think of this about with a large structure fire or some type of building fire. Most people that have cyanide poisoning are usually dead at the scene. Most usually do not survive to get to the hospital. If they do, they're very lucky. Cyanide is going to inhibit aerobic metabolism and leads to severe anaerobic and a gap acidosis. They're almost always fatal. If they make it to the hospital, they're probably unconscious. If it's not recognized soon enough, they're going to have a bad outcome. If you're in an area that does a lot of fine metal or precious metal work, they use cyanide in that process as well for doing things with gold, silver, platinum. We can do lab levels, but typically if we suspect cyanide, this patient shows up from a structure fire and they're unconscious, most will prophylactically go ahead and administer the reversal agent. In some areas, fire may carry this and give this to patients, but this is definitely a fatal drug. Been used in a lot of suicide attempts by people. You ingest it, you're usually dead within a minute. Cyanide is simply going to inhibit oxidative phosphorylation, causes severe acidosis and death. If you are concerned about it, the recommendations are to treat it. Don't wait on the lab test. We'll intubate early, give high-flow oxygen, and our drug of choice is the cyanokit. The cyanokit contains hydroxycobalamin. Hydroxycobalamin will turn that cyanide into cyanocobalamin. It turns it into B12. Now it's a non-toxic substance, and the patient will urinate it out. Typically, if this is effective, their urine will have a very pink tinge to it, and often their skin and whole body will look very red. They have that kind of flushed red color that we look if you've ever given somebody B12. Very quick way to do this. They may require repeated doses, but if we're concerned about cyanide, go ahead and reverse them. Don't wait on the lab test. So this 30-year-old comes in agitated. Well, there's lots of differences for that. It could be they're agitated about their bill, or they lost $200 in the casino and the slots, or maybe it's just $20 in the slots. Right, Martha? But there's our vital signs. So 120, 160 over 90, temp's 102. That's interesting. History of depression, they're taking sertraline. What am I worried about? Serotonin syndrome. Because guess what they're also taking? St. John's wort. because they read about that on the internet. And hey, St. John's wort really helps with your mood. And I'm not happy with mine right now. I want to fix. So now we're taking St. John's wort. So what can we do to treat serotonin syndrome? Treatment is very supportive. But there is a drug we can consider giving. Cyproheptadine is an antihistamine that also has serotonin blocking properties. So if somebody comes in, it looks like serotonin syndrome, we may go ahead and administer benzos if they're seizing, secure their airway if it's not secured. But cyproheptadine can be given to antagonize the serotonin receptors. The downside is only available as a pill, so either have to be able to swallow or you have to give it down an NG tube. But definitely this may be beneficial in serotonin syndrome. Cooling measures need to be instituted because this can cause severe hypothermia just like neuroleptic malignant syndrome can. But hyperthermia is one of those big things that makes me concerned about things like serotonin syndrome or neuroleptic malignant syndrome, your anticholinergic effects. Sometimes your sympathomimetics. So there's several things there that may help us look for this. In this case, we think about the need for cyproheptadine. And our last few things, acetaminophen we talked about earlier. Acetaminophen is a great drug. It has a great safety profile unless you overdose on it. It's not the acetaminophen, it's what our liver turns acetaminophen into. Within 4 hours of an ingestion, all that acetaminophen will be absorbed, and now we'll know if that patient is toxic or not. Phase 1, very benign symptoms. They get some GI distress, some malaise. Lasts about 24 hours. Phase 2, now we start seeing some significant organ dysfunction. That usually starts within about 24 hours of the ingestion. And then they move into multi-organ failure and almost always death. But time is critical because I only have a small window to treat these patients. Acetylcysteine, Mucomyst, NAC, and now IV formulation, Acidote, is my drug of choice. Acetylcysteine replaces glutathione. Glutathione is the enzyme my liver needs to metabolize the metabolite of acetaminophen. In normal doses, we have enough to metabolize it, not a problem. But in an overdose scenario, our liver is exhausted and there's not enough glutathione left, so we replace it. This is very effective. It started within 8 to 12 hours. It has very little benefit after 24 hours. Unfortunately, that first 24 hours, the symptoms are not very straightforward. They're very benign, and that sometimes leads to problems. But if it's 24 hours of ingestion, we'll usually start acetylcysteine and watch their LFTs. Dialysis may be helpful, but usually after 24 hours, there's already significant hepatic injury. They're going to need supportive care, and we'll have to watch their outcome. And then salicylate toxicity. A lot of over-the-counter products that contain a salicylate. A lot of over-the-counter cough and cold stuff. So definitely this time of the year, we see a lot of accidental acetaminophen as well as salicylate exposures. Very similar to other things, aspirin is really good at controlling fever, has anti-inflammatory properties, but in large doses it also inhibits aerobic metabolism. It's going to affect our ability to produce energy. And so these people develop a significant gap acidosis. That's where they're almost always tachypnic. We see that really rapid Kussmaul breathing. They develop a severe acidosis, and they die from that usually. But lots of over-the-counter products that contain a salicylate. A lot of your over-the-counter GI preps we talked about earlier, skin preps, skin cleansers, topical pain relievers, those all contain some type of salicylate. So we want to get that drug level at 4 to 6 hours. That'll give me an idea if they're toxic or not. Charcoal is helpful if given early. Support their perfusion. We'll initiate bicarb therapy. The whole goal there with bicarb is to alkalize the urine as well. If we make the urine more alkaline, they'll excrete more acid. And the whole goal here is to trick the kidneys into getting rid of more acid until we can get them to hemodialysis. But if they're truly acidotic, this is the person I want to dialyze as soon as possible. Hopefully this is the patient I do not have to intubate. If we have to intubate this patient, make sure you match their minute ventilation. Don't put them on a respiratory rate of 12 a minute. You'll kill them. Calculate their minute ventilation before intubation. They're probably breathing 30 or 40 times a minute. We need to maintain that if we intubate them. If we have to, we try not to paralyze them so they can keep their own minute ventilation. But it's really important to maintain that minute ventilation after intubation because that respiratory rate is what's keeping their acidosis at bay and keeping them alive. And that is the end of toxicology. You'll get some more tox lectures in the next couple of days, but that's just a brief skim of some of the drugs. For those of you that are going to be here, the rest, we'll go into much more detail.